Okay, let's unpack this. House dust mite allergies. If you're one of the millions living with them, you definitely know it's more than just, annoying sniffles.
Absolutely, it's
It's
relentless.
a constant battle with sneezing, the itchy, watery eyes, that nose that just will not clear. And for many, there's the breathing difficulties, too, if asthma is involved.
Right. And this isn't just discomfort, is it? It really creeps into your sleep, saps your energy.
Makes daily life, work, school, everything
Yeah.
feel like a massive uphill struggle.
Yeah.
And again, something you can't really avoid.
That's the killer, yeah. They're everywhere. And look, while we have standard medications, things like antihistamines, nasal sprays, they're essentially just managing the symptoms.
Symptom relief, not a cure.
Exactly. They don't address the underlying allergy itself. And importantly, they don't fully control symptoms for everyone. There's a real unmet need there for people who are still suffering despite using these treatments.
Yeah, absolutely. Which brings us neatly to the core of this deep dive. We're looking at a recent, very detailed assessment by NICE, that's the National Institute for Health and Care Excellence in the UK.
Right.
They've been scrutinizing a specific treatment option for these house dust mite allergies.
And the treatment in question is called 12 Standard Quality House Dust Mite Sublingual Lifilizate. It's quite a mouthful.
It really is.
So we'll mostly call it SQ-HDM SLIT. The brand name is Acarizax, and it's a type of allergy immunotherapy. The idea is to gradually desensitize your body to the allergen.
Okay, so our mission here is to peel back the layers of this specific NICE assessment. It's guidance TA1045, if you want the reference. We're going to look at the evidence they weighed up, pick apart why they made the recommendations they did, and crucially, figure out what this actually means for you if you're living with these allergies.
Okay, sounds good. So just to set the scene, quickly the conditions. House dust mite allergy, it mainly shows up in two ways, right?
Yep.
Allergic rhinitis, that's the nose and eye symptoms, and allergic asthma, affecting your airways, your breathing. And you can have one or you can have both.
And the source material we looked at, especially the input from patient experts, it really hammered home the huge impact.
Yeah, that came through strongly.
They talked about the toll on physical and mental health. The exhaustion from terrible sleep, the anxiety about symptoms flaring up, feeling limited in what you can do.
And the sheer stress of trying to control dust mites in your home, which is, let's be honest, almost impossible.
Totally. Those patient views were vital, weren't they? Highlighting that even with the usual symptom relievers, control is often just not good enough.
Yes, and there's a real desire for treatments that might reduce that long-term reliance on things like corticosteroids, for example.
Okay, so before we get to this SQ-HDM SLIT treatment, what is the standard approach right now? How are symptoms usually managed?
Well, for allergic rhinitis, treatment usually starts with things like antihistamines, maybe intranasal corticosteroids, nasal sprays.
Right, the usual suspect.
Yeah. If symptoms persist, you might add other meds, combinations following established guidelines. For allergic asthma, it's typically a kind of stepwise approach,
Okay.
starting with inhaled corticosteroids, adding things like long-acting beta agonists, and then escalating treatment if things aren't controlled, possibly towards biologics for really severe cases.
Right, so where does an immunotherapy like SQ-HDM SLIT fit into all that? It's trying to change the underlying allergy, you said.
Exactly. So it's typically considered after those initial symptom-relieving meds have been properly tried, and symptoms are still persistent and sort of moderate to severe.
It's not first line.
Definitely not first line.
Huh.
And for asthma that's not well controlled by inhaled steroids and is linked to rhinitis, it might come in before you jump to more advanced options like biologics. Think of it as another layer for specific patients who aren't getting enough relief from standard care.
Okay. And getting access, I mean, your GP might suspect it, but confirming it's specifically house dust mites.
Yeah, that usually needs specialist testing, skin prick tests, maybe blood tests.
So starting the treatment is more a specialist thing.
That's the expectation, yes.
Yeah.
The decision to initiate this kind of immunotherapy, the first prescription, that would typically happen in secondary care with allergy specialists. Though perhaps repeat prescriptions could potentially be handled in primary care later on.
Got it. Okay, so tell us exactly what is 12 SQ-HDM SLIT. You mentioned it's a lyophil, is it?
Yeah, fancy word. It just means it's a tablet that dissolves very quickly under your tongue, sublingual.
Oh.
And it contains a very specific standardized extract of house dust mite allergens. So tiny amounts of what you're allergic to, given in a controlled way over time.
Right. And who is this actually licensed for? Because the license and who NICE recommends it for can be different things.
Very true. The marketing authorization, the license, is quite specific. It's for adults 18 to 65 with persistent moderate to severe house dust mite allergic rhinitis if their symptoms aren't adequately controlled by things like nasal sprays and antihistamines. It's also licensed for adults 18 to 65 with house dust mite allergic asthma that's not well controlled by inhaled corticosteroids. A&D is associated with at least mild to severe rhinitis.
So 2 adult groups there.
Yes. And it also has a license for adolescents, aged 12 to 17, but just for the persistent moderate to severe rhinitis, again, despite using symptom relievers.
Okay, so 12 to 65 is the age range. Key things are existing meds aren't cutting it, and for the asthma indication, it has to be not well controlled and linked with rhinitis. And the price.
Yes, the source mentioned a list price of £80 to $12 for a pack of 30 tablets, but as always, the actual cost to the NHS is likely subject to confidential discounts.
Standard procedure. Okay, let's get to the heart of it, the clinical evidence. NICE assessments always hinge on this. What trials did they look at?
The main evidence came from 2 big multi-center randomized controlled trials, so good quality studies. MTS-04 focused on adults with asthma, and MT-06 looked mainly at adults with rhinitis. Both compared the treatment against a placebo.
All right, the gold standard design. But the source material flags a key challenge here, doesn't it? How well do results from these sort of clean trial environments translate to the, well, messy reality of everyday NHS practice?
This was a major point of discussion for the assessment committee, absolutely. They identified several limitations in how the trials were designed when trying to apply those results to the UK context.
Like what?
Well, for instance, in the MT-04 asthma trial, the participants, they technically had partially controlled asthma, not necessarily the not well-controlled asthma specified in the license.
So not quite the target population.
Not precisely the population defined in the marketing authorization. So the data wasn't a perfect fit for the specific group the treatment is licensed for in terms of asthma severity.
That seems pretty significant straight off the bat for the asthma part. What else was different?
A really big one was that the MT-04 asthma trial included a mandated 6-month phase where participants had to gradually reduce and stop their standard inhaled corticosteroids.
Hang on, they stopped their normal steroid inhalers.
Yes, this was done specifically to see how well the immunotherapy prevented asthma attacks without the background steroids. But, and this is critical, that is absolutely not how asthma is managed in the NHS.
Right, you wouldn't just stop someone's controller inhaler like that.
Exactly. So this trial design, particularly that withdrawal phase, made it incredibly difficult to assess the treatment's effect on asthma when used alongside standard inhaled steroids, which is how it would be used in reality.
Wow. Okay, so that makes interpreting those asthma results for the NHS tricky, to say the least.
Very tricky.
Were there other differences between the trials and standard care?
Yeah, a couple more. Both trials restricted the use of some common symptom-relieving medicines that people in the NHS would normally use alongside immunotherapy if needed.
Okay.
Also, the trials themselves were relatively short, about 12 to 18 months, but the recommended duration for allergy immunotherapy to get the lasting effect is typically 3 years.
So they didn't even run for the full recommended treatment course.
No, they didn't capture that full 3-year duration and any potential benefits accumulating over that time or persisting afterwards. Anything else. One final point the assessors noted was that the main efficacy measurements in the trials were timed outside the peak pollen season. Now, house dust mite levels are generally high year-round, but they felt this timing might still affect results, particularly for asthma exacerbations, which can sometimes be triggered or worsened by pollen exposure on top of the dust mite allergy.
Okay, so the committee was looking at this trial data, but with some, let's say, significant caveats about how directly it applied to NHS practice.
Definitely. A healthy dose of caution was needed.
So, despite these limitations, what did the trials actually find? Did the treatment work? Let's start with allergic rhinitis, mainly from that MT-06 study.
Okay. For rhinitis, the MT-06 trial showed a statistically significant reduction in symptoms and also in the amount of symptom-relieving medication people needed compared to the placebo group.
So, statistically, it worked. People on the treatment did better.
Yes, the scores were definitely better on average for the group getting the SQ-HDM SLIT.
Okay, that sounds positive. But I remember reading something in the source about whether this difference was actually clinically meaningful. What's that about?
Right, this is a really important distinction. Statistical significance tells you the result probably isn't just down to chance.
Okay.
Clinical meaningfulness asks, Is the difference big enough to actually make a noticeable, worthwhile improvement in a patient's day-to-day life?
Ah, I see.
And in the rhinitis trial, while the treatment group did better, the size of that improvement wasn't always massive. For example, the relative reduction in the combined score for symptoms and medication use was about 16%. Some guidelines suggest you might want to see more like a 20% difference for it to be considered clearly clinically relevant for many patients.
So better than placebo, but maybe not a night and day difference for everyone.
Potentially, yes. And the quality of life improvements measured were also smaller than a commonly used threshold, what's called the minimum clinically important difference.
Okay, and what about the placebo effect?
That was also quite large in the trial. People taking the dummy tablet also reported improvements, sometimes quite significant improvements, up to 40% on some measures.
Wow.
Which, makes the relative benefit, the difference between the active treatment and the placebo, look smaller.
So summing up for rhinitis.
The committee's view was, yes, a benefit was shown compared to placebo. It was statistically significant. But the actual size of that benefit remained a bit uncertain. However, taking everything into account, including expert opinion, they felt it was likely to be clinically beneficial for many people.
Okay, understood. Now, what about allergic asthma? That was mainly the MT04 trial, the one with the steroid withdrawal.
Right, so MT04 showed a statistically significant reduction, 31%, in the risk of having a moderate or severe asthma exacerbation compared to placebo.
31% sounds quite good on the surface.
It does. And this is the huge, but this reduction was seen primarily during that mandated inhaled corticosteroid withdrawal phase.
Ah, back to the non-real world scenario.
Exactly. It showed a benefit when patients weren't on their standard asthma treatment. When they looked at overall day-to-day asthma control, using scores like the ACQ Asthma Control Questionnaire, during the phase where patients were still on their inhaled steroids.
Yes.
There was no statistically significant difference between the group getting SQ-HDM SLIT and the placebo group. And the very small difference that was seen was definitely not considered clinically meaningful by standard thresholds.
So let me get this straight. For asthma, the trial showed a benefit mainly in a situation that doesn't happen in the NHS, and it didn't show a meaningful benefit on everyday control when used closer to how it would be used.
That's pretty much the crux of it, yes.
That sounds like a major problem for the asthma indication.
It was. Because of that trial design, especially the steroid withdrawal, the committee felt they just couldn't conclude that SQ-HDM SLIT offered a meaningful clinical benefit for asthma when compared to established care as used in the NHS. The evidence simply didn't support it for the asthma indication on its own.
Okay, so the trial picture is, let's say, complex. Clearer for rhinitis than for asthma in the NHS context. But the assessment didn't just rely on trials, did it? They also considered real-world experience.
Yes, and that's often valuable, especially when trial designs have these kinds of limitations. Clinical experts and patient representatives shared their observations from actual practice.
And what did they report?
They mention seeing benefits that aren't always easy to capture in trial scores, like patients feeling less fatigued or potentially being able to reduce their overall corticosteroid burden over the longer term, things that matter a lot to patients.
And I think there were some other studies mentioned, observational ones.
Correct. Studies with names like BSACI and RE-LI were submitted. Now, observational studies have their own limitations. They aren't randomized trials.
Right.
But they did offer some supportive evidence for longer-term benefits, particularly for rhinitis. And they suggested the positive effects might even increase beyond that initial treatment period covered in the main trials.
Okay, what about actually taking the treatment? It's a tablet under the tongue every day for potentially 3 years. Adherence must be a factor.
A huge factor. And there was a bit of conflicting data here. In the controlled clinical trials, adherence was really high, like 80–90% of people took it as prescribed.
As you'd expect in a trial setting.
Right. But then there was a real-world study from Germany which reported much lower adherence rates, particularly dropping off by year 3.
So which rate is more realistic for the NHS trial level or the lower German study level?
That was debated. The clinical experts argued that the specific group being considered here in the NHS, people whose symptoms aren't controlled by other meds, who've gone through specialist assessment, they're likely to be highly motivated to stick with it.
Makes sense. They're actively seeking a better solution.
Exactly. And they also pointed out that the NHS provides ongoing monitoring and support for patients on long-term therapies like this, similar to standard asthma or rhinitis care, which should help maintain adherence.
So the thinking was that NHS support plus patient motivation would lead to adherence closer to the trial rates.
Yes. Based on that expert input, the committee decided it was reasonable to assume adherence levels in NHS practice would likely be similar to the high rates seen in the clinical trials rather than the lower rates from that specific German study.
Okay, so we've covered if it works and if people might take it. The other big piece for NICE is always cost effectiveness. Is it good value for the NHS's money?
Absolutely. This involves complex economic modeling. They try to calculate the cost per QALY gained.
QALY.
Quality adjusted life year. It's a standard measure combining length of life and quality of life.
Got it. And the source indicated there were some pretty big uncertainties and disagreements in these economic models.
Yes, quite significant ones, which really affected the bottom line results. Key areas of debate included things like how long the benefits of the treatment would actually last after you start taking it after 3 years. That's a big assumption.
Right. How long does the desensitization effect persist?
Exactly. And also, crucially, estimates of how much money the treatment might save the NHS by reducing other healthcare use, like fewer hospital visits, GP appointments, specialist consultations for allergy problems.
The potential cost offsets.
Yes. The initial estimates for these savings provided by the company were considered likely to be overestimated by the committee. There was also discussion about the best way to actually measure and value the quality of life improvements within the model itself.
So depending on the assumptions you plugged into the model about duration of benefit, cost savings, quality of life, you could get quite different answers about whether it was cost effective.
Precisely. All these uncertainties made it really challenging to pin down a single, reliable cost-effectiveness number.
Okay, so bringing everything together now, the clinical trial data with all those caveats, the real-world perspectives, the adherence debate, the tricky economics, what was the final verdict? What did NICE Guidance TA 1045 actually recommend?
Okay, so the committee ran the economic model using what they considered the most plausible assumptions, trying to account for those uncertainties. For people with allergic rhinitis only, the result came out at approximately 18,126 pounds per QLOY gained.
18,126 pounds.
Okay, for people with allergic asthma plus rhinitis, the figure was higher. It came out over the usual benchmark of 20,000 pounds per QALY gained. The exact figure is confidential, but it was definitely above that level.
Right. And NICE typically considers things cost-effective if they're around 20,000 pounds per QALY, maybe up to 30,000 pounds in some circumstances. But you mentioned uncertainty plays a role.
Yes. Given the high level of uncertainty they'd identified throughout the assessment about the true size of the clinical benefit, especially for asthma, the problems generalizing the trial data, the long-term assumptions, the model structure itself, the committee decided that the acceptable threshold in this specific case, because of all that uncertainty, should really be considered around that 20,000 pound mark, perhaps even slightly lower. They couldn't be confident justifying a higher threshold given the doubts.
Okay, so with that context, what were the final recommendations? Let's break it down by condition again.
Right. For allergic rhinitis, 12 SQ-HDM SLIT is recommended as an option.
Right.
Specifically, for treating moderate to severe house dust mite allergic rhinitis in people aged 12 to 65, provided they've been diagnosed properly and their symptoms are persistent despite trying adequate courses of symptom-relieving meds like antihistamines and corticosteroids.
And the reasoning.
Because the clinical evidence, while uncertain in magnitude, did show a benefit, and the cost-effectiveness estimate of around 18,000 pounds per QIY fell below that acceptable threshold of roughly 20,000 pounds, even with the uncertainty considered. So, value for money for that group.
Makes sense. Now, for allergic asthma.
For allergic asthma, 12 SQ-HDM SLIT is not recommended.
Not recommended.
Specifically, not recommended for treating house dust mite allergic asthma in adults, even if it's diagnosed correctly, associated with rhinitis, and not well controlled by inhaled corticosteroids.
And the reasoning there.
Primarily due to the lack of convincing clinical evidence from the trials, especially because of that steroid withdrawal issue and the failure to show a meaningful benefit on overall asthma control when used alongside standard NHS care. Because the clinical benefit wasn't clearly established for asthma in that context, it consequently couldn't be considered cost-effective for that specific indication on its own, with the ICER being above the acceptable threshold.
Okay, and this seems really important. What about people who have both conditions? Many people with dust mite allergy have both rhinitis and asthma.
Yes, this is absolutely critical to understand. The guidance is very clear on this. If you have both house dust mite, allergic rhinitis, and allergic asthma, you can still get the SQ-HDM SLIT treatment. But only if you meet the criteria for the recommended rhinitis indication.
So based on the rhinitis.
Exactly. If your rhinitis is moderate to severe, it's persistent despite trying other meds, and you're between 12 and 65, then you qualify for the treatment based on the rhinitis recommendation. The fact that you also have asthma does not exclude you. The recommendation is for the rhinitis, and if you meet those criteria, you can access it, even if your asthma alone wouldn't have qualified under the non-recommendation for asthma.
Okay, that's a really crucial nuance. So the door isn't closed for people with asthma as long as their rhinitis is bad enough to meet the criteria.
Precisely.
So bottom line, what does this nice decision mean for you, the listener, who might be affected? When does this actually happen?
Well, the immediate impact is for those eligible patients with allergic rhinitis. Because NICE has recommended it as an option, there's a funding mandate. The NHS in England has to make funding available for this treatment within 90 days of the guidance publication date.
Which is March 5th, 2025.
Correct. So funding should be in place by early June 2025 in England. In Wales, the timeline is usually a bit quicker, typically within 2 months.
Okay, so translating that directly, if you are between 12 and 65, you have moderate to severe house dust mite allergic rhinitis, and it's causing you significant problems even though you're using your nasal sprays or antihistamines properly, then this treatment, SQ-HDM SLIT or Acarizax, should now be available as an option for you.
Yes. You'd need to discuss it with your healthcare professional, most likely a specialist in allergy, to see if it's the right choice for your individual circumstances.
And if your main problem is house dust mite allergic asthma that isn't well controlled,
then the treatment isn't recommended specifically for the asthma. However, repeating that key nuance, if you also have moderate to severe allergic rhinitis that meets those criteria we just mentioned, persistent, despite other meds, right, age group, then you could still be considered for the treatment based on that rhinitis recommendation.
it really does highlight the complexities, doesn't it? How these health technology bodies like NICE have to juggle everything.
Absolutely. They're weighing up clinical trial data, which often has limitations.
Right, like the ones we discussed.
Then factoring in real-world evidence, patient views, which aren't always easily measured, and then they have to overlay the hard economics, what the health service can realistically afford. It leads to these quite nuanced decisions about which treatments get funded and for precisely which groups of patients.
It's a fascinating and sometimes frustrating process, I imagine, for both clinicians and patients trying to access new therapies. A constant balancing act.
It really is. Balancing the potential of innovation against the need for robust evidence and sustainable healthcare spending. It ultimately shapes what options are available for managing long-term conditions like these severe allergies.
Definitely gives you a lot to think about regarding how these decisions get made.